hopefully you can all see the slides. Yeah, so welcome everyone to the Social Prescribing Innovators Programme Showcase. We're really excited to see so many people on here today who care about social prescribing, improvement, innovation, and supporting those incredible people on the front line to become leaders. So why are we all here today? There's probably quite a few different reasons. You might be passionate about social prescribing, improving and evolving. You might care about healthcare evolving to meet the needs of communities in a proactive, population-driven way. That's what the Social Prescribing Innovators programme really aims to do. Or you might be more interested about the process of our programme, looking at how people on the front line can be supported and empowered to carry out change. Or want to know a bit about the pilots and how they were started, can be run and evaluated in a bottom-up way. And so this is our aims for today. We're hoping to demonstrate the importance of driving innovation in social prescribing through the Innovators programme approach, share some of the impacts. You'll get to hear from some of the people who have been involved running those projects and getting all their partners on board and engaging local communities. And we also want to show that the learnings are scalable and this approach can be taken other places, and we'll have a panel discussion touching on some of those key points as well later on. So I should probably introduce myself as well, actually. I'm Jenny. I'm a project manager in the social prescribing and community-based prevention team at Transformation Partners in Health and Care. We used to be HLP, and we're really kind of thinking from a London level about how to make social prescribing and the personalised care roles thrive and sustainable. And as part of that, we set up this programme. I won't introduce all the other people you'll hear from today, and that they can introduce themselves as we go on. And we will be hoping to have some of your interaction today as well. So there's a code to join just here, Slido. If you haven't used it before, you can either get out your mobile and use the QR code, or you can use that link, which hopefully one of my colleagues is able to pop in the chat as well. So yeah, just please join, and with the panel, you'll be able to submit your questions to them. So you'll be able to use the Slido for that as well. So if anything pops in your mind throughout that you really want answered, please pop in there. Or if you have any more general questions or comments for speakers, you can put that in the Teams chat as well. Right, so yeah, as I mentioned, you'll be hearing from some of the projects. We'll be going a bit over the background of kind of why we programme, what it involved, what we've found out so far from it. Then we'll be moving on to the panel discussion, which we have a range of amazing people joining that, people that were involved in the project, people leading the voluntary sector, and some really passionate clinicians as well. And then we'll share with you what else we're doing in this space to kind of continue the work that's already happened, and some opportunities to get involved further as well. Right, next I'm going to pass on to Katie Coleman, who's going to give us a fantastic introduction to why this is so important. Over to you, Katie.
Thanks so much, Jenny, and hi everybody. As Jenny said, my name's Katie Coleman, so I'm a GP in Islington, and in North Central London, ICB, I'm the clinical director for primary care, but I've recently joined the Transforming Partners in Health and Care team to be their clinical director in community-based prevention. So it's really wonderful to be working with them and with all of you on some of these programs of work. I just really wanted to say, I suppose, there's so I've been really involved in sort of supporting personalised approaches to care for a long time now. But in around 2012, sort of near the beginning of the inception of CCGs, I remember sort of reading, to me, which was a really seminal paper by NHS Diabetes called "Thanks for the Petunias." And I don't know how many of you have read it, but if you haven't read it. When I read it, it was a real moment for me. And it was at that point that I realised that health alone couldn't help people with long-term conditions, and that if we were going to help support people with long-term conditions and complex health needs, we needed to think about addressing the wider determinants of health, and how we can find ways to use the agency of general practice to connect people into their local communities, so that people felt enabled to address what mattered to them. And in fact, what I did at that time was I worked with colleagues in Age UK Islington, and together we came up with this solution called Care Navigators. And from then started my passion for social prescribers and social prescriber link workers. So it's been something which I've been absolutely bought into for a really, really long time. And I know that actually many of our voluntary sector organisations have been doing social prescribing for many years, long before 2012. But for me, that was the start of it. But as a GP working in a pretty deprived area of Islington, I know how challenging it can be to work with underserved communities, and how exhausting it can be if you do that full time. And in fact, you probably it's a rare thing to find a GP working in a deprived area who works full time, because actually it's just not sustainable. And that goes really for anybody working in that environment. And so for our social prescribers, it's really important that we think about how we can support them to be able to continue to sort of work in those areas. And one of the ways that we can that can happen is by actually sort of expanding their skill sets and sort of providing them with opportunities to undertake sort of quality improvement and look at ways of improving outcomes for the people that they're serving. So I'm really keen to support this Innovators programme, because it really does start to do that, and it's really sort of seen the potential that it offers our social prescribing colleagues to make sure that they're in an environment that sort of helps them to sort of learn new skills, to sort of support the system, to sort of see the opportunities, and sort of really to do that from a bottom-up approach. So it's a real pleasure for me to be here today and to be able to sort of share with you all the successes of the programme and think about how we can spread it. But before we kick off today, I just wanted to sort of tell you about a recent encounter I had with one of my PCN social prescriber, and I can see that's Latina, so big shout out to you, Latina, who is the social prescriber in my PCN, who I work with really closely. So we were having a conversation. We often sit together in a room on a Wednesday, and we were having a conversation about the fact that a number of our patients who are applying for blue badges, they were really struggling to access that sort of support. And we know that blue badges are really important for certain people, because it really helps to stop them from being isolated from their sort of community activities. But actually, they were really struggling to get the right information in order to enable to ensure that they were so they were awarded their blue badges. And so together we were sort of trying to sort of bounce off ideas about what we could do to ensure that there was that consistent information collected often from GPs, from the occupational therapists who are doing the sort of assessments in the local councils. And we came up with some good ideas, but then we kind of came up against a bit of a stumbling block, which is that both Latina and I are working flat out. So we have very little capacity, and also we don't have the support in our sort of infrastructure around us to actually do that quality improvement work, that capability to sort of do that quality improvement work. And so for me, it was a real sort of moment of like, wouldn't it be great if we had a social prescriber innovators sort of programme in my PCN in North Central London around sort of the people who I'm working with day in, day out. So it really, really sort of I sort of feel it's really important that we think about how we can support our social prescribers and programmes like this to really take forward that sort of bottom-up change that will enable us to build capacity and capability for locally led innovation, that will enable us to bring stronger networks and partnership working across different sectors, localities or specialisms, that will upskill the workforce to develop meaningful solutions to challenges they face, will empower the frontline social prescribers so that they're working with their local communities to transform services for their patients, and develop skills and support their career development, so that we're retaining our leaders of the future. So I'm really excited to be part of this programme, and really looking forward to seeing and hearing about the showcase of some of the work that you guys have all been doing. So thank you so much for allowing me and enabling me to be here today.
Thank you, Katie. I think that's just really highlighted that, you know, social prescribers and people on the front line, they have a huge amount of experience, skills and assets to improve services and support patients how they need to be supported, but they need time and they need to be enabled to work on things like this in order to really build that capability. So thank you. I'll now hand over to my colleague Molly, who I co-lead the programme with, to go into a bit more about what the programme actually involved. So over to you, Molly.
Thanks, Jenny. Hi, everyone. Yeah, so apologies in advance. I've got a bit of a cold today, so if I start coughing or sneezing, apologies for that. But yeah, thanks everyone for joining. And then, yeah, I'm just going to, as Jenny says, give a bit more information about the background to how we came about this programme. So the Social Prescribing Innovators programme, it was a pilot aiming to test the impact of investing in the front line to overcome challenges and transform services. And we saw this as an opportunity to maximise impact for social prescribing services across London through developing a programme of support that provided the assets, training and connections required for social prescribing services to explore a problem, test a solution, assess success and impact, and document and share their learnings. And in building a strong network of people as well across social prescribing, VCSE and healthcare, we hoped to provide a platform for the innovators to share widely their project ideas, approaches and learnings that were developed over the course of the last 6 months. And the programme also acts as a blueprint for developing future cohorts to maximise impact in social prescribing, whether that's in supporting innovation, quality improvement, or in other skills. The approach can also be easily applied to other specialties and sectors, and we're developing a resource as well to support others to run similar programmes, which we'll share a bit more information about later on in the event. Next slide, please, Jenny. Thank you. So we've heard from social prescribing services across London that common systemic challenges faced include recruitment and retention of social prescribing link workers due to burnout or lack of career progression opportunities, access and engagement in the social prescribing services, particularly among cohorts that are disproportionately affected by health inequalities, and also in demonstrating the extensive benefits and impacts that social prescribing can have on individuals, communities, and the wider health and care sector. So we know that social prescribers and services on the front line have the insights needed to be able to tackle these challenges, but they don't always have the space, assets, or tools to be able to drive forward solutions. So the Social Prescribing Innovators programme provided an opportunity for the front line to connect and lead on service transformation projects to better meet the needs of their communities across London. Next slide, please, Jenny. Thank you. So in giving the frontline social prescribers and services access to just a small amount of funding, skills, training and a peer network, 12 projects were able to test new approaches, engage with stakeholders involved in social prescribing across the system, develop wider project management, evaluation and quality improvement skills that are useful for wider professional development, and also lead meaningful projects impacting change in their local area. So the key impacts that this programme has driven towards include providing a platform for sharing approaches, learnings and impacts across projects, and developing resources and guidance that will be useful for sharing with the system to support others in leading similar cost-effective and sustainable approaches. Also, it's driven towards some amazing impacts already at a local level across each of the projects, whether that's for patients and communities, in reducing health inequalities, and also for social prescribing services, as well as the people involved. And you'll hear a bit more about this from the projects presenting today. It's also developed an upskilled and empowered collective of leaders who are committed to improving social prescribing services in their local area and can also advocate for the impact of social prescribing. And finally, it's developed stronger connections across social prescribing, VCSE and healthcare, fostering partnership and integrated delivery of care, which is centred around population needs. Next slide, please, Jenny. Thank you. So what was involved? So as I said, this was a pilot programme which included a small amount of funding and wraparound support for participants to innovate against their chosen challenge. And the approach and activities aim to support projects to develop their own solutions to these challenges through coaching and to develop leadership skills, supporting personal growth and development, as well as enabling the delivery of meaningful projects that had far-reaching impacts. And you can read more about the programme and activities here on this slide, but also on our online project page as well. So a board of experts were convened across the social prescribing system as well that were involved in shaping the pilot, in the decision-making process for selecting successful projects, as well as in supporting projects throughout their life cycle and development. And the approach taken was really first of its kind in driving sustainable change through upskilling and connecting the workforce to assets, training and resources to develop meaningful projects, through enabling co-production and partnership working across sectors, developing a bottom-up approach to frontline challenges pan-London, and also in enabling systems to proactively target cohorts that are facing health inequalities at a local level. And now I'll hand over back to Jenny, who will talk a bit more about the evaluation work with UCL London. Thanks, Jenny.
Thank you. Yeah, so as mentioned, this is a pilot. We're testing different things out. So it's really important that we understand what the impact has been, what's worked well and what hasn't. So as well as gathering feedback throughout and kind of having those reflections and discussions, we are doing a more formal evaluation with UCL, and you can see the 3 aims of this piece of research.
Got a new role that I was approached by a American company when I was doing the work with Carnegie Hall.
Yeah, great. Always happens at least once. Yeah, so the aims of threefold of this, really looking at what was the impact of the programme on people accessing social prescribing services. Have communities been able to access social prescribing more because of it? What was their experience of social prescribing services and the ability of participants to influence these 2 things? And how we're doing this is we really wanted to hear through from the participants, because we think they're the key in this kind of change process. So we're having some in-depth interviews and some questionnaires, and what we'll gain is understanding those impacts. As mentioned, we'll know what worked and what didn't, and we'll have recommendations for the system in terms of how this kind of work can continue, which we'll continue to share with everyone here today. We're also planning a session in a couple of months' time, which is going to share some of the kind of rich learnings from the interviews and try and get your thoughts and opinions on what sensible recommendations are like. We really want this to not be just an academic piece of research, but something really applicable to your practice and what will be most helpful to learn from it. So keep an eye out for that, definitely. And we just wanted to share, before we hear in depth from some of the participants, what have been some of the initial impacts. We've seen some great impacts on patients and communities, people accessing social prescribing who haven't before, such as ethnic minority, people from an ethnic minority background. There's been a huge increase of people from that background accessing the service in Camden. There's been a lot of engagement with migrant and refugee communities through hotels in Ealing. And there's also been a lot of impacts on the workforce themselves. So feeling more satisfied with their roles. People that have been on the programme have described it as a lifeline to them. But also people who aren't directly involved in the programme, they've been supported through some of the projects, through having volunteers, and that's led to better job satisfaction and retention. And some projects have looked at the impact on the system, such as freeing up capacity, GP appointments being saved, and how we can really demonstrate the impact of services as well. A project which you'll hear from today has looked at how you can evaluate the social prescribing service. And there's much more information on our website about what the individual impacts of each project have been just in a short time, kind of 6 months as well. Also, we wanted to share a bit about what we've learned more generally. So as I mentioned, some people have said it's really been a lifeline in a world where social prescribers are burdened with very high caseloads and don't get time to really use all their experience and influence services to adapt. It's been a lifeline. It's also led different leaders of services to completely transform the way they're thinking about what's possible for social prescribing and the partnerships they have. And importantly, social prescribers have felt much more close to their peers. They felt supported in this really network of leaders that have been developed, and they're better able to solve their challenges. There's some quotes there that you can read about from the different project leads. So, for example, someone said it's felt like the most important thing they've done in their career today, and someone else has said that it's allowed them to shape the service in a way that always felt like a pipe dream. You know, always looking at that other case study or that other piece of best practice and thinking, oh, I don't think I can do that in my area. It's actually made that possible for people. And I think it's also always important to share some of the challenges. So getting kind of buy-in around the approach. We know not everyone's comfortable taking a quality improvement approach and knowing what that actually means in simple terms. Finding time to engage with the programme, it comes down to really committing to freeing up some time to make this work happen. And the sustainability of these projects, we don't want them to just be one-off pilots, but to continue to inform what's happening at a bigger footprint and continue to impact patients' lives. So, yeah, I've shared a bit about the impact, but I think it's great to hand over to some of the people that have been involved themselves. So first, we've got, you're going to hear from 2 different projects. You can feel free to put any questions you have in the chats or comments or reflections. But first, I will hand over to Lucy and Emma, who are the co-project leads in Barking and Dagenham.
Hello, Emma. I don't know if you want to go first.
Yep, can do. So hi everyone. Yeah, so I'm Emma. I'm work for Barking and Dagenham Council. It's part of the Healthy Lifestyles team, and we run the social prescribing. So very different to how a lot of other social prescribing projects are run around the country. That actually we all work for the local authority rather than being recruited in through the PCN areas across the borough. So we are commissioned to run social prescribing. So for us, it was really important to sort of how can we work a lot closer with the GP surgeries across the PCN areas. So that sort of part of the project was sort of the importance of working sort of together. So working with care coordinators across each of 5 of the 6 PCNs from our borough, and looking at the better ways of getting referrals through that weren't having to take GP appointments. So yeah, what was the best way of that we could do that? So Lucy.
Yeah, hello, I'm Lucy. I'm one of the PCN care coordinators. So my role is to kind of facilitate communications between patients and GP practices. And what I found when I started the role was because of COVID, there was a real breakdown in communication. it's been really, really challenging to kind of get the patient's voice to be heard, because GP practices are under so much pressure as well. So lucky enough, I met Emma, and we kind of had a bit of a brainstorm and thought it was better if we could create a more of a wraparound service for patients. So that's what we did. We run various different pop-ups. We invited patients to kind of non-clinical settings. So we would use community spaces, and they loved it. We targeted like diabetes patients, mental health patients, and they said that they felt that they were really being listened to. A lot of the times they would cry because they were overwhelmed. So yeah, back to Emma.
Yeah, I think because working for the local authority, we had access to these spaces, but we as link workers didn't have access to the patients. So working with the care coordinators, they could target, sort of, we worked together the different cohorts. So sort of each, as I said, we were on 5 PCN areas. So each sort of PCN had over the 6 months probably had about 5 or 6 pop-up clinics, sort of generally sort of 1 or 2 a month. And then we had a sort of a big day on National Social Prescribing Day where all 5 came together, also bringing in sort of third sector partners to sort of basically sell their wares, but then also we could put direct referrals through. But it was just a different way of not having that patient just going to the GP to get the referral through. You know, we could talk to the patients there and then, face to face. As Lucy said, they were sort of very, you know, some coming in very emotional, because actually not just having that 10 minutes of sitting down with a medical practitioner or a nurse or, you know, whoever, but actually having that longer to go through all of the issues that we could then, as sort of link workers and care coordinators, support them going forward and getting their referrals through.
I think because we had it in community settings, a lot of the times there were other services there. So if someone came in and they needed a community food bank, if we were in the library, we could take them over there. There's like the Homes and Money Hub, we could take them straight there as well. So I mean, they were really getting like this personalised care that we're talking about. I think some of the difficulties have been personalised care it feels like a very new concept for the way that GP practices work, because you don't see quick, immediate results. This is something that we're investing in the patient, we're investing in the communities that we work in. So kind of changing hearts and minds has been probably one of the biggest barriers that we face so far.
And I suppose, as you can see there with the figures sort of throughout, even though, yes, we might have invited 19,000 patients across different cohorts and things, we actually saw 399 patients. So 399 people being seen face to face is massive. But even just sort of having an estimate of how much that can save from them not going to the GP, they could come because they would have received a text message through Lucy and the other care coordinators to invite them to this non-medical appointment. And then from those that attended, you can see 87% have actually gone on to receive signposting or forward referrals. Yeah, we did get a few that came through that thought it was a medical appointment, so we sort of unfortunately had to sort of say no, we can't do that. But then even going forward, we haven't put it on here, but from the success of the pop-ups, you know, got managed, sort of my managers and things have seen sort of people coming into these buildings, and we've now sort of working together with other health professionals that we're now sort of using the same kind of concept and sort of doing different sort of, I think we've had a pilot GP drop-in clinic, and we've now got them booked in once a month. So it's utilising sort of GPs coming as well, but then also we'll have social prescribing. As I said, I work for Healthy Lifestyle, so we have Healthy Lifestyles input there as well. So it's actually, you know, it started and helped us as well as a sort of a local authority and health service to sort of move that ongoing and keeping that relationship together and going forward.
Is there anything else?
There's a question in the chat from Katie asking, what was the most effective way of changing hearts and minds?
Oh, wow. I think it's a big question. It's still in the process. It's a battle. Do you know what? the best thing that we've done is by talking about what we're doing, by showing people within the PCN, this is what the patients are saying, this is how they're feeling, and actively getting that patient experience heard as this is what they were feeling and their frustration, and they were scared, and this is how they feel now. Because like I said, it's not something where you can just meet a target. It's not going to happen like that. We really have to invest in our communities, and the more we can cheerlead about what we're doing, the more people we can get involved. And this is why we decided to bring all the PCNs together, so collectively we were all doing the same thing. Like that will be the way to change, I think. I hope that answers your question.
Thank you. I think one of the things that I find amazing about your project is that Lucy and Emma didn't know each other that well before the project, and I think it just shows that this work has brought different services working in partnership. Lucy employed by the PCN as the care coordinator, and Emma employed social worker through the local authority. I just think it's an excellent example of how the personalised care roles can come together to tackle some of these issues and engage all the different PCNs within a borough. So I thought that was really fantastic.
Yeah, I think Emma, for me personally, Emma and Emma's manager, the whole social prescribing team have been so supportive, because as a care coordinator, it can be very lonely. You don't have a team around you. So I may not have still been in this position if it wasn't for this project, and being able to use my skills. I'm used to work with vulnerable people, and this has given me the opportunity to do that. And Emma's been great, and now I've got a musical theatre buddy forever, I think.
Great, thank you both. If is there any other questions? Feel free to put your hand up if you don't want to pop it in the chat. Oh, Dan, yeah, feel free to come on mic.
And apologies that I'm coming in late. I was doing a teaching session this morning. Just a question, it's not a criticism, I just want to say that, but I've just got my calculator out, and 399 is 2% of 19,000. Obviously, it would have been a disaster if all 19,000 had responded. But it's absolutely by no means a criticism. Somebody once told me that, these people who hand out leaflets outside tube stations for gym membership, I can't remember the figure, but they have to hand out about 20,000 to get one gym membership or something like that. 20,000 leaflets translates into one gym membership or something like that. So the response rates are very, very low for all these things. I guess just one thought, really. It's a 2%, and as you say, you managed to save, whatever it is, 15,500 nearly in reduced GP appointments. So that's good. Any thoughts about how one could even get, say, nudge 2% up to 3% or 3% up to 4% in terms of response rate?
I mean, I think it's hard, because obviously where we chose the cohorts, there's no, we don't know. They might not have any issues with regard to, because you think for social prescribing, it's, I mean, as I've said there, the majority, 53% of those that have come through need housing support. Yeah, from the 19,000, it's sort of 18,000, it could be 18,500 actually don't need any support. So that might be why they haven't come. So yeah, I suppose that's the hard part, is how do we, we're offering the service, so it's a drop in. Then it is, if you need that support, to then come and sort of get that. So I suppose it might be that we have to go to more people to get those numbers up, but actually, yeah, it's a hard one.
It may not. This is what the trouble is with looking at stats and things. So our pop-ups run for 4 hours, and I think we did 10 or 12. And at one of the pop-ups, I mean, they had something like 53 people turn up all at once. So, which is a lot when you're trying to deliver a personalised care approach and you want to take time with your patients and sit and really have meaningful conversations, that was way too many people that turned up for us. So we were never, our focus wasn't really about how many people were coming through the service. It was definitely about the quality of care that we could provide the people that really needed it. So yeah, so that wasn't something that majorly concerned us, but I think it would, the number of people coming through the service would improve once we did it more regularly, once people started talking about it and the word got out there. But yeah, it wasn't really a factor for us. We were actually concerned that we were getting too many people through.
Great, thank you. I hope that answers the question. I can also see there's a comment on the chat from another from Robin, who's a care coordinator involved in the project, just sharing that kind of, I guess if something like this hadn't been done before, then it was just kind of showing this is here, this is available to you. That's kind of the first step, and then the next step might be something else. I think what it also got me thinking was the data we have and the information we have on our residents and communities is such a key thing. How do we identify those people that need help the most so we can really tailor it to them? Yeah, really important thing that different people are thinking about and working on, as in the national team, for example, with the minimum data set. That's kind of a way to really capture what's happening with the data in social prescribing. Well, if there's no other questions, I'll just say thank you so much to Lucy and Emma. Your presentation was great. It's great to hear about all the different impacts you've seen, and yeah, I hope to see this continue in the future. If you've got any more questions, please feel free to pop it in the chat, but they will also be joining the panel in a bit as well. I'll now hand over to our next person presenting, which is Alex. So Alex is actually going to talk a bit more about data and evaluation, because that was the focus of their project. So I'll hand over to Alex now. Thank you.
Thanks, Jenny. Hi, so I'm Alex. So I'm the My Community Lambeth Services Manager at Age UK Lambeth. I'll just introduce myself. So I've been Age UK Lambeth have been working with the primary care networks in Lambeth since 2019. And so I think we kind of approached this thinking about, okay, we've been working with the PCNs for a while, we've been kind of delivering a service for a really long time. But every time we kind of develop the service in any sort of way, our social prescribing link workers aren't consulted. It's being completely driven, by PCN, NHS requirements. And, we're sort of losing a wealth of knowledge, people on the ground who are delivering this work, our patients' voices aren't kind of being there and represented. So we kind of use this opportunity to really kind of look at how we can sort of evaluate our service, because obviously, we've been working since 2019 with PCN, so we're obviously doing end of year evaluations, but they're very much kind of like data driven and kind of like, what does the DES say? How are we going to kind of change our service to reflect that going into the next financial year? Whereas this kind of gave us an opportunity to actually properly evaluate it, listening to the voices of those in our service, our link workers, and actually kind of think about, what do we need as a service? What do our community need to kind of, make the service work, as well as obviously, what the NHS is saying we need to do and what the new DES is saying, but actually, let's properly evaluate it on all these different levels and kind of, make it work for everybody. So how we kind of approached this, we identified sort of 3 key stakeholders we wanted to work with to sort of evaluate the service. So they were the PCN, our clients, and of course our link workers. And we kind of thought we'd do this in a 2-prong attack, by starting with kind of survey feedback. So kind of collecting as much kind of, feedback from those 3 key stakeholders, which would then form the basis of focused workshops. And from those workshops, we kind of, start doing more collaborative exercises to kind of review and design our new service moving forward. Unfortunately, we were hit with a few kind of staffing issues. So although, this program has been fantastic and has helped us focus, it's kind of taken us a little bit longer to kind of complete some of this. So we're still kind of in the workshop phase at the moment. So we've got our link worker workshop actually happening tomorrow, which is really exciting. But yeah, it's taken us a time to get here because sadly I sort of lost my project assistant. But we've kind of completed all of our survey feedbacks. We'll then be doing one with our clients. And the feedback we've got from the surveys has been really helpful. And it's already kind of helped to sort of identify some key areas that we can kind of develop within the service. And we've already started to kind of work on this within AGK Lambeth. So seeing a lot of key themes coming around community hubs and like peer support. And that's kind of both for link workers and for the patients that we're supporting. So we're now starting to build into, our service development next year, like how can we kind of work with PCNs, with the community, sort of set up these hubs and have spaces that patients can support one another. It also feeds into kind of, the proactive social prescribing. So, we're able to kind of use the NHS's requirements, but actually sort of hear what the community are saying and kind of design that service so it's actually reflecting what people want. And then obviously peer support. So we've kind of looked at, right, what do link workers need, kind of feeding into what Jenny was sort of saying, retention is such a key issue. Link workers are so, so busy, so overworked, deal with some really complex issues, but actually kind of hearing that and having the evidence is kind of enabling us to go back and say, right, this needs to be built into our service. We need this. This is what we need. If it means we need to apply for additional funding, then that's what we'll do, because we've now got that evidence. We've now done that thorough evaluation of our service, and actually this is what we need to make it work. So it's kind of, I suppose, just talking about being part of the Innovators Fund. I think that was my quote that Jenny sort of said about it being a pipe dream, which is actually really true. So being part of this program has really, even with the challenges, even losing kind of like a key member of my project team and it kind of just being myself running this, and I'd love to say that this is the only part of my role is working with social prescribing, but I manage a very large team with about 7 different projects. But being part of this project has actually enabled us to stay focused rather than kind of going, right, well, this is what we want to do this evaluation, and then kind of, time restraints coming in and going, okay, I don't have time, I don't have the resources, we'll just do that usual report that we send out at the end of the year. Actually being part of this program, being really supported by, peers, by the team, has actually meant we've kind of still got that dedicated time. We'll still kind of focus on it, and we're actually starting to now get the results and the information and that we really wanted and that we've never seen before. And like I said, we've been here since 2019 working on social prescribing, and we've never had this opportunity to ever kind of really go in depth into our service. We've kind of like, done a few snatches here and there. We've kind of looked at the data that's come in, we've looked at the referral numbers, we've, but we've never actually kind of gone, right, okay, actually, let's see what you're saying and let's analyze it. So, tomorrow's session, we're really going to be focusing on, what's working, what isn't working that's come up from these surveys, and kind of problem solving together. It's not going to be me kind of going there and saying, right, okay, I've heard what you said and this is what we're going to do. It's going to be a really collaborative approach, and that's something that this program has really enabled us to do, which, has kind of kept us focused and given us that time and the resources that we've never seen before. And it's really kind of encouraged engagement from our link workers, because they're actually having the chance to have their say and actually shape the service development. And our patients are also having that opportunity, because it's all well and good doing this work, but actually is it what the patients want? Is it what the community is actually asking for? And kind of identifying those key stakeholders has meant that everyone's kind of having their say. And we've learned a lot. We've kind of, because of this funding, we've kind of done everything in one big lump of evaluation, and that's not sustainable. It's quite time consuming to do everything all in one go, and you've obviously got time restrictions because you want to get it done by the end of the financial year. But this has actually enabled us to kind of review this process and kind of go, okay, what do we need to do to make this sustainable? What do we need to put in place over the next year so that when we come to the end of March, all of this will be built in, and this evaluation process won't be such, you know, an in-depth thing. We won't necessarily need all of that time and resources that, you know, thankfully this Innovators Fund has given us. So we're now starting to build in kind of, you know, collecting feedback, and obviously we do collect feedback, but it's never been done in this kind of specific way, going through a survey. That means you can kind of analyze it and compare it over the year. So that's going to be built in, like, you know, a meeting with our kind of communications team, so that it's actually going to be built in, and it's actually, we're going to be using that across the organization now. So what we've learned from this project is kind of, you know, benefiting, you know, other AGK member services. And so, you know, this, I guess really I just want to sort of sum up that it's given us the opportunity to really kind of do an evaluation that I never thought I'd, you know, be able to do, and hear voices that have probably not contributed to evaluation work, particularly in our service. Obviously don't want to comment on every social prescribing service, but it's kind of, you know, given us a chance that we would not have seen without it. And, you know, it's been a really enjoyable piece of work, and I think we've really learned a lot about our service and about, you know, the community that we're serving, and hopefully taking that information will then create an even better social prescribing service moving forward. Thank you.
So much. Thank you so much, Alex. I think it's amazing to hear how all the hard work you've done and the experience of the program are going to have such like longevity for the service and help you gain that continued investment in social prescribers. I think that's amazing. And I think it's also great to hear how the way you've gone about the evaluation is really co-produced. And I think we have the tendency to think, oh, you know, data and numbers is one thing, and community approaches and working with our people is another thing. And I just don't think it has to be. And I think your work's really demonstrated that. So thank you so much. Does anyone have any questions, comments or reflections for Alex? Feel free to put in the chat or put your hand up. And you can continue putting things in the chat once we've moved on as well, because they'll be monitoring that. Just concede, Dan's just said, sounds odd to say this, but the idea of co-producing a social prescribing service with social prescribing link workers and patients is very rare, I guess. Yeah, I think it's the traditional way of working. Let's design something and then maybe get some feedback. But yeah, what happens when we actually bring all the people around the table first? Katie, did you want to say something around that?
Yeah, so tragically it is rare, isn't it? And we have to sort of ask ourselves, well, why is that? And I think that what we have is that there's a slight tension, isn't there, in our system, because the funding currently for social prescriber link workers sits within the primary care network contract, and is therefore directed by the PCNs and the GP practices that sort of like receive that sort of funding. And one could argue that that's possibly not the most supportive approach to ensure that actually the local services are responsive to the needs of local patients and residents, and also the people who are delivering that services. So I suppose for me there's a question of like, if we could pass messages on to our system partners around how can we ensure that social prescribing services and social prescriber link workers have the opportunity to shape services going forward, what would that message be to the system and to sort of those people who are determining contracts going forwards, recognizing that in 2024 we're likely to have a new GP contract? And I know that that's a big difficult question, and you may not be having an answer here today, but I think it's something that I would really value hearing from people, because it would help us to sort of like get that message up to the national sort of the people who are sort of like looking at these contracts going forwards.
Yeah, thank you, Casey. I think that's so important to reflect on this work, the current context around this work, and how these roles can continue to be recruited, supported and invested in, and that is 100% in light of the GP contract. And I know there is engagement going on at the moment. There is very much a big question mark over what support, investment or kind of stuff happens around those roles that were considered R's roles, non-clinical roles, which social prescribers are, and what happens in the future. So they're looking for people to be involved in that. There was a round table a few weeks ago, and I'm sure there'll be more opportunities to feed into that. And I think it's really important that people here today who get it and people who are invested in social prescribing are part of those discussions. So yeah, hopefully that's something we can share with everyone and our networks as well. So thank you. Right, we've heard from 2 fantastic projects, so I hope that gives you a flavour of the kind of things that happened on the programme. I'm just going to hand over to Charlie now. He's our amazing quality improvement coach, just to give any thoughts or reflections he has he'd like to share. Oh, he says 1 second. He's on mute, I'm not sure. Oh. Maybe he has to get the door or something. Okay, we'll see if he comes back online. But we can move. Charlie is also going to be a part of our panel discussion. So if you have any specific questions for him, then please submit them. So yeah, Leanna's just posted the Slido in the chat again. So anything you'd like to ask the panel, please put in there. We're going to have around half an hour for this. And I think we'll spotlight all the people that are part of the panel, so you'll be able to see them. We've got all our lovely panel members here, a range of different people. So we've got Jagan and Katie, who are our fantastic clinical leads, Lucy, Emma and Alex, who you've heard from today. We've also got other people that have been involved in the project. So we've got Frank, who led one of the projects in Hillingdon along with the social prescribing service, and Kerry, who has been involved in the men's project in East London as well. So to save time, we've put a bit about them on the slides here today. And of course, as mentioned, we've got Charlie, who I think is back online now. I don't know, are you able to unmute? Is it not working? Okay. Perhaps I'll let Molly get in touch with you or Leanna to see if we can get that working. Perhaps dialing in or something. Right, yeah, so we've got eight fantastic people on the panel. Molly's monitoring the questions on Slido and I'll be handing them over to people. Molly, is there a question that we've got ready from the Slido?
Yeah, so just looking at the Slido now, nothing's come through from the audience just yet, but we could, I'm not sure if Charlie's able to, no, still not working, but one question that we thought might be useful to ask the whole panel would be around sort of why you think it's important for the NHS to invest in work like this. I don't know if we want to kind of open it up to the whole panel and anyone kind of contribute.
Yeah, you can just put your hand up, or Jagan, go for it.
Thank you, and thanks for the really important question. So as you can probably, and you know, we're going to speak to a lot of the converted. So I think the NHS has changed, and Katie alluded to some of the problems with the commissioning element earlier on, of how we commission services. But actually, a lot of our services and what we're aiming to do, including some of the GP contract stuff, is really about population health. And population health means, and very much that whole integrated kind of working with partners, and that includes our voluntary sector colleagues as well as our kind of normal statutory colleagues, about how we really make what we do on a daily basis worthwhile, i.e. of some meaning. And that really drives to the kind of personalisation element going forward. And I think personally, and I'd be curious to hear from the other panel, we've probably got the greatest opportunity for us to really start listening with the new kind of contracts and the way that our primary care networks and the kind of population health drivers, as well as our prevention kind of element that we're really pushing hard. We've probably got the greatest opportunity now to really showcase some of the stuff that we've seen earlier on today, to really think about how we can do things slightly differently and get our commissioners to really think differently going forward. And one of the biggest issues we've always had, and Dan and Katie and a lot of our colleagues will know, we've always struggled with this whole thing about evidence and, you know, is this really the right thing? And are you sure we're going to, if we invest in this, will it deliver the changes? And actually, we are talking about the long haul. If you look at children's social prescribing or wider, you're going to be talking about, for example, changes in their life. You can't measure that straight away. You might be able to in 20, 30 years. The same with social prescribing, and some of the comments being made. You know, these drop-ins. It's about really changing the methodology and the way that we manage and, you know, manage our population in general. And one thing I learned during my time in the leadership positions, as particularly during COVID, we found, no surprises, that a large proportion of the population weren't being listened to. So when we came to actually say, oh, let's give you a COVID jab, they were saying, well, you've never really engaged with me before. You've never really understood my wants and issues, and you have never really understood that actually the services we're commissioning aren't really doing the thing to support us. And I think that's why I think these pieces of work and why we need to do this is because it's proving the case for population health. It's proving the case for prevention. And certainly, I think one of the bad things about the GP contract in terms of primary care networks, it's firmly put social prescribing link workers in primary care. Well, necessarily, actually, probably it needs to be thought of a whole system approach. It shouldn't be just about GP practices. It should be everyone thinking about how can we talk to our residents or talk to our local people, and that includes the people who are working the front line, to do things slightly differently, and how can we change the service that we all like to see in the future. And I think for me, that's why these pieces of work really matter, because it's in line with the thinking of the contract, it's in line with the integration agenda, and certainly I think the intelligence that we're getting from projects like this, or the ones that we've demonstrated, and a lot of other projects that we've seen, it's really showing that actually it is about partnership working, it is about proactive working, and getting co-production really part of that kind of anything that we do, we should be really thinking about co-production. I think for me, the big thing is really to try and kind of challenge the ICBs, the integrated care boards, and those place-based partnerships to say, are you really doing what you think you're doing? And could we do things slightly differently? And that's what these projects are all about, because it's not going to happen at the board. And for example, where I'm in North East London, it's going to happen at place, or the street, or those little neighbourhoods. That's where the change happens. That's where people notice the differences. So, Jenny, to start off, I think that for me is the number one. It's the opportunity we've got to really change things slightly differently. And it's going to be hard. There's no question about it. The NHS is going through another change. But I certainly think we are the advocates. We're the people that can say it's got to be different. But I'm sure Katie might have some other bits as one of my colleagues. But that's how I feel. I think for me, this is critical work because places are developing now really at speed. And the more intelligence we get, the better it will be. Thanks.
Thank you, Jagan. I think, yeah, you highlighted, working at place level and thinking about how things are changing, and this programme as a way of supporting that. I wondered if we could come to Frank to share a bit about his thoughts around, Frank, you're working at the borough level in Hillingdon, and you've been involved in one of the projects. Did you want to share any thoughts?
Yeah, so in terms of just building on what Jagan said earlier, I'm a head of transformation for the primary care networks across Hillingdon, and we're looking to work towards integrated neighbourhood working. So we are on that journey at the moment, and the ambition is that we all have a co-location model. So therefore, we'll have the district nursing service, we'll have voluntary sector services, as well as primary care staff all working in one location. So we are working towards that at the moment. And the ambition is that social prescribers will be at the heart of that. However, just to manage expectations, we're at the beginning of the journey, and we do appreciate that the social prescribers, they need to develop as well. And this is why we participate in this program, because we accept with an aging population, with increasing number of long-term conditions, that they need to be upskilled. And with a significant number of people with mental health conditions, dementia, as well as challenging behaviours, our current social prescriber workforce doesn't actually meet that need. So that's what we're working towards in terms of our project. But getting back to your original question, it's integrated neighbourhood working. That's the way forward, because PCNs or GP practices do not have the capacity or the capability to manage an aging population. So that's my response. Thank you.
Thank you. Does anyone else from the panel want to share any thoughts or reflections?
Hi, so it's Kerry here from Social Action for Health. I just wanted to really ask the rest of the panel, I suppose, and especially picking up from Jagan's point and Frank's point, who do we need to convince? Because in this meeting, we're preaching to the converted here. We all absolutely believe in the power of social prescribing, getting the communities involved. And some of the phrases, for example, that popped up from Lucy and Emma's presentations were like invest in our communities and all that. So we're totally bought into that model. But how do we get it changed? Because I find as a voluntary sector representative, I go and sit in various boards and I speak to various people, and at that individual level, everyone absolutely understands it and social prescribing, and we need to do this and that. But actually go up, systemically, we can't seem to make that change. Is it politicians? Is it, chairs of boards? Yeah, I'd just like to throw that out there.
Thank you, Kerry. I'll go in order now. Teams have a function where they throw the order of hands. So I'll go over to Frank first.
Yes, so I think all the people and all the key stakeholders that you mentioned, they are the people I believe councillors or members are absolutely critical to actually influence the system. I also believe that NHS England has a pivotal role in terms of driving policy improvements. So I would say start from the top and then work down to the ICB and the ICS. So that's mine. Thank you.
Thank you. Katie?
Yeah, so I think that we all have a responsibility, don't we? So we all have a responsibility as those champions for sort of for personalised care and social prescribing to be a bit of a thorn in the side. So I often get sort of like you know, I'm a bit of a broken record when it comes to sort of personalised care and sort of like making sure that that sort of information and that sort of insight is being sort of shared. And I'm not one to just sort of let things go. I sort of keep going and going and going. So that being said, I think it's all of our responsibility. However, just building on Frank's point about sort of integrated neighbourhood teams, and I don't know if people have heard about the Hewitt report. So in the Hewitt report, there was sort of a recommendation that 1% of budget should be sort of like proportioned to support prevention. Now, we all know in this room that prevention actually needs to happen right upstream before actually sort of things have really happened. So we need to see that we need to sort of be sort of advocating for that 1% of investment to support prevention. That will then enable us to sort of really get upstream to sort of support our communities where they need to have that support to sort of address things before they become an issue, looking at that lifestyle issues, looking at those sort of wider determinants of health. So we need to sort of like make sure that we're sort of raising all of those sort of points that have been sort of flagged by sort of those politicians that you sort of have just referenced. So let's all be champions. Let's be a broken record, and let's just remind everybody that prevention is where the investment needs to be, so that we can all get upstream and use those community resources to improve our sort of residents' outcomes.
Thank you, Katie. I think that's a great call to action there. Right, I'll just go to the next two hands up before I move us on to the next question. I think I can actually see one of our people who formed our Social Care Innovators board member team throughout the programme has got their hand up. Oh, I'm raising my hand by accident. Anthony, is your hand up? Is there something you'd like to share? Anthony is our lived experience representative on our board. So I don't know if that was an accident or if you would like to say something.
Yes. One of the findings of the Barking and Dagenham group was that 53% of their, for want of a better term, clients were presenting with housing problems. Now, how do social prescribers cope with housing problems? That's what I want to know. 53%, I think, is rather a low percentage of people, because more people have housing problems, in my experience. That's the root cause of most of their difficulties. And we can't help with those, can we? Or can we? Integrated neighbourhood teams?
I suppose that's
sure.
Yeah, sorry, because I'm local authority, we've got the links into the housing teams. But you're right, there is if they're already on social housing lists, or yeah, they're looking at sort of changing sizes and that's what we're getting a lot through. There isn't anything we can do. I mean, we've spent over the sort of the 3 years that we've been running social prescribing trying to get the information through that. Just because you're getting a social prescribing referral through isn't going to make you go up the social list or the sort of bidding list any quicker. But there are other issues. It's not just those bits. There are sort of other bits that we do get, sort of whether it's mold or whether it's adaptations in the house. There are a lot of other things that come through. It's just that they will get banded under the one sort of topic of housing, really.
Yeah. Thank you. I think we're getting quite a few questions into Slido, so if that's okay, can we move the discussion of this question to the chat that focuses on housing specifically? I'm just getting messages about all the Slido questions. I think we really want to hear from the panel kind of more around the Innovators approach and why that's important. And yeah, I wonder if anything's come through on that, Molly.
Thanks, Jenny. Yeah, there's a question in the slider around, will there be funding available to roll out and scale up the most promising projects?
Jagan, would you like to come in?
Yeah, so it's a good question. I think there are, as many of you who know, and I'm sure our local authority colleagues will know, there's always pop money coming down at thelastminute.com. And we use something. I always say to all our innovators, have something ready to go, because you'll be surprised. We got to put in a bid by the next day or 2 days time. So my advice is always have something. But in one case, I would say there are every year each of the ICBs get health inequalities money, and you know, health inequalities and some of the work we're doing are really interlinked. So that's one pot. There is also a lot of the ICBs are committing to innovation and doing elements as well. And we tend to see all the trusts put money through and say, we've got a great scheme. But you'd be surprised, we'd never see anything coming from primary care, really, particularly on this kind of thing. So the short answer is there is limited budgets in its current form, but there are always separate budgets for things like inequality, population health, innovations funds, and things like this that come through separate pots. So the answer is yes, there may be, and B, have something ready, because you'll be surprised that what can be done, and it is down to the commissioners to really think outside the box. I've even had a social prescribing project in one area that has it come from winter monies. For the NHS gets traditionally money for winter, and it was really to help people during that time. And you know, there was a place that that put in a bid and they successfully got the funding. So what I'm trying to say is there's always, and it really does come down to your clinical directors that may be at place, but also the place-based leadership to kind of say, you know, there is some funding and things, and there's normally a consultation when it comes to these kind of things. I got to be honest, it's the people who are able to provide a business case really quickly. It is, and anyone who's been in a charity or a voluntary sector will know that business casing is part of your daily life. You know, we've got to have always ready, because it's so difficult to get funding for the voluntary sector just traditionally anyway. So so that's my short answer, Jenny. It's not the perfect answer, simply because it isn't a perfect funding formula at the moment. But I don't know if any of my colleagues have anything. And don't underestimate, in London, we have a London funders group and charities. So, for example, in North East London, one of the biggest charities, Bart's Charity, they're actually funding a social prescribing for children in one of our places as well. So there are also other big charitable groups that also look for projects as well. And I know Jenny will know that we very much know the London Mayors. There is a whole London funders group where people are doing things, you know, they're contributing money to just because of philanthropy, you know, in that respect. You know, they want to do something that worth some meaning. So I just wanted to throw that in, and I know the team are aware of some of the funding groups as well, so we can always help and support you in that way. Thanks.
Thank you. Does anyone else want to share anything in response to that question?
Can I say something? And apologise for my strange connection earlier. Can you hear me now? Okay, is that working?
Yeah, all good. Thank you.
Okay, sorry about that. So yeah, what I was going to say was just in kind of the context of the entire programme, and this event today is to showcase it, isn't it, I think? And I've been working in primary and secondary care for 20 years and doing quality improvement for the last 8 years in that. And this has been one of the most rewarding and exciting programs to be involved in. And I checked my emails earlier, and it's exactly a year ago since I had my first meeting with Leanna and the team. And when we first met, they had a vision that what they wanted to do was to help support projects and choose them carefully, and support them with quality improvement, but not to make it too quality improvement focus, more to help the projects work through their aims, establish them, and go all the way through the journey so they reach the other end with a successful outcome. And that was their vision. And a lot of people don't have that at the beginning of a program, but this particular program did have that. And so we adapted the training to be really practical. And then in the meantime, the team chose very carefully the projects to whom they'd give the funding. And those projects then started receiving the training, and they all wanted to do work and learn things, but not listen to me talking about theory and stuff. And the only complaint, we had 1 or 2 complaints, but the biggest complaint we ever had was, you're not letting us have enough time in our breakout rooms to do these exercises, to chat to each other. There was another complaint from somebody saying, last time we didn't have any homework, but this time I've got homework, and now I'm really happy because I've got homework to do. And all the teams did their homework, and the homework was basically working on their projects. And so between each training, there were 4 training meetings. Between each training, they come back, they do stuff, they'd be chased up by the team, they had lots of support, and it was incredible the amount of work that people did, you know, over the space of the few months they were doing it. And I think today shows the success of that. So the people who did the work were there, but actually the whole design and approach by Leanna, Jenny and Molly, and people they're supported by, has made this work as well as it has. And so when this question about is there funding available, there's often funding available in the NHS. You can give it to people, and I've been given funding in the past from other jobs, but actually that's not much use a lot of the time. You need to be able to use it really effectively and really well. And this program, the design of it, has really helped to support highly effective use of not a huge amount of money, but got incredibly efficient outputs from that money, in my opinion. So congratulations to everybody, and especially the people who've done that work who are on this call today. And apologies, as I say, for my strange IT problems at the beginning. Back to the panel.
Thank you, Charlie. Thank you for sharing that. I'll go to Molly. Have we got another question from the Slido? I think this will be our last question, perhaps.
Yeah, I was going to say the same, but we do have one last question around why this approach should be prioritised over other initiatives.
Who would like to come forward on that one? I think Frank was first. Over to you, Frank.
Yeah, so my immediate response to that question is that we would need, it's advisable that we move away from a medical model to a non-medical model, and that's the key point. We do know, which I did mention earlier, we've got an aging population with increasing number of well, the technical terms comorbidities, but with long-term conditions, strokes, heart attacks, cancer, etc., etc. So we need this approach to move away from the medical model, because there's only sufficient number of medication you can actually prescribe, and self-management with support from social prescribers is the most effective way moving forward. So I've tried to be as very succinct as possible, and hopefully I've answered your question. Thank you.
You're on mute then, Jenny.
Sorry, I was saying thank you. And Katie, would you like to share?
Yeah, so I think so particularly with the focus on sort of the innovation and using sort of quality improvement. So so we know that our ICBs will have priorities, but actually enabling that bottom-up approach and enabling people who, as I mentioned in my sort of like introduction, can feel those, identify those pebbles in their shoes that sort of cause them pain on a day-to-day basis, and actually to have to be empowered themselves to address those sort of challenges, and then to use those insights to develop services and share good practice and innovation more widely. You really start to get that groundswell, that bottom ups of like innovation and opportunity that really makes a difference. And as we've identified, it will help to retain our staff, these people who are actually doing that work to support people with long-term conditions, with multimorbidity. And if we don't do something to support those people who are supporting our residents on a day-to-day basis, to look at those wider determinants of health, then actually we really are going to sort of struggle to address the inequities within society. So yeah, so let's sort of like allow that bottom-up approach. Let's support those people who can do that on a day-to-day basis. Let's give them the skills through quality improvement and system improvement work, and sort of give them the voice in their local system. So that's why I think we should be supporting this approach.
Great, thank you so much, Katie. And I think that's a great point to end on. Just want to say a huge thank you to all of our panel members. I think that went very quickly and we probably haven't addressed all your questions, but we'll aim to address them after the event and share any thoughts and reflections from ourselves and the panel members after. But yeah, thank you so much to our panel. We're now just going to take a few minutes to share what's next. And I think just from the questions asked and thinking about why this should be invested in, I think it's a great time to think about, yeah, how can we go about rerunning this again? How can we work with everyone in the room today and ICBs and NHS England to ensure the approach continues? And I'll hand over to Molly to just highlight some of the things we're doing next around this and how you can get involved.
Thanks, Jenny. So yeah, as Jenny said, we wanted to share a bit more about what we've done since the programme ended to support the participants on the programme, but also some of our ideas for what we could do going forward and how we could support the system to implement similar ways of working. So following the programme, we've continued to support participants through one-to-one coaching sessions, where they could come in and kind of discuss opportunities for funding or kind of challenges they want to unpick. We've also shared a graduate pack with resources across each of the programme meetings, and we'll be also providing peer project support sessions as well, for projects to connect and share learnings and problem solve. We also held a graduation event on the 31st of March, and this was focused on really celebrating the project's engagement and achievements throughout the programme. And it was an opportunity for participants to connect with board members and wider stakeholders who had been involved in the programme or who were interested in hearing more about the programme, to kind of connect and reflect and share ideas. So what's next? So moving forward, we're hoping to share the learnings from the programme widely to really scale this approach. So we're developing a toolkit, which is essentially a resource for the system to share the components, the key guiding principles, assets and resources that are required to deliver a programme of this nature. And we're aiming to launch this in June. And all of the guidance in this resource will be transferable to different topics within social prescribing, as well as different geographies, specialties and sectors as well. And we're really keen to shape this as well with anyone who's interested to share their feedback. So please do reach out to us if you'd like to feedback on the first draft. We'll share our contact details at the end of these slides as well. We're also more than happy to connect with anyone who's interested to hear more about the programme on a kind of one-to-one basis, and we can have a call just to discuss how you could potentially implement something similar in your local area. And yeah, we'll also be sharing more impacts and outcomes on the programme from the evaluation, which is ongoing. Thanks, Jenny. So these couple slides we've shared with you already, but we'll also share the slides again after the meeting. But these just give a bit more information about the toolkit resource, the purpose of this, its contents and the target audience. Next slide, please, Jenny. Yep, also kind of more information here about what's included in the toolkit. And final slide, please, Jenny, as well. So please do reach out as well if you'd like to discuss further anything that we've kind of covered today, if you have any questions, or as I said, if you'd like to feedback on the toolkit, the first draft, or kind of discuss opportunities to start something similar, or any kind of support for doing something similar in your local area. So that's our contact there that you can reach out to us. And please do as well check out our project page, which we've shared in the chat, but it's also linked on the slides there, which has more information about the programme, the background, but also the next steps and all of the impacts and some of the resources developed throughout the programme from each of the projects. So yeah, thank you so much for joining, everyone. We hope you've enjoyed the session, and we really hope to hear from you soon.
Just want to say, yeah, thank you for everyone that's joined, and just kind of sum up the day that, you know, I think we've shared a bit about the background, the approach, why we did it, what we found, heard from the amazing people involved, and what some important and interesting people from around the system think. We really want to continue these conversations. We're keen to run it again. We think it's a hugely cost-effective approach, and we're exploring with the different ICBs in London around how it can be taken forward, but we're keen to explore with all of you around how we can continue this. We think, you know, just a little bit of investment can go a really long way for using this approach, and can help us tackle some of the really big priorities in healthcare today. So yeah, please get in touch. Please join us at one of our future sessions around developing the recommendations. Get in touch over email, and we'll be sharing the recording and the extra resources from today, including the toolkit that Molly mentioned. But yeah, thank you. And thank you to our panel members and presenters today. Yeah, just thank you for joining.
Thank you.
Thank you.
Thanks, everyone.
Take care.
Thanks, Molly and Jennifer. Thanks, everyone. Bye-bye.
Bye.
Bye.
Thanks. Bye-bye.